Hi everyone, thanks for joining us today for this lucrative lunch hour. We're going to be discussing implant care in the hygiene chair. I want to start by saying this is merely a glimpse into our clinical training that we provide to teams. The training on implants is actually a few hours in length and goes over things in much greater detail. So this presentation today just summarizes a few areas of information. Our agenda for this lucrative lunch hour is to review what makes the patient a candidate, to discuss the implant process, to review periodontal classifications of implants, and also to discuss implant care and maintenance. If you have patients in your practice that you care for, or your practice even places implants for patients, it's important that you know the process of identifying which patients are candidates, how to care and clean for them while they are in your hygiene chair, and how to help patients understand how to care for them at home. Today, we are going to discuss what makes the patient a candidate for an implant. A patient is a candidate for an implant if they choose to replace a missing tooth to restore their smile, or perhaps to restore form and function for chewing and to restore their bite and address their occlusion. A patient may also be a candidate to avoid supereruption of opposing teeth or to avoid teeth shifting and drifting. Your patient may also be a really good candidate if they're interested in replacing a missing tooth without the need to restore healthy teeth on either side with a bridge. Next, we are going to cover the diagnostic image needed for identifying if a patient is a candidate or not for an implant. The image needed to evaluate whether or not your patient is a candidate for an implant is called a CBCT. The benefits of a CBCT are less radiation, it's more detailed in identifying both root and alveolar fractures, and also provides coronal, sagittal, and axial views. It can show both hard and soft tissues, identify lesions related to disease, and accurately measure dimensions of the jaw. It also is helpful to evaluate sinuses and nerves and can pull a pano image from the CBCT. Here's a prime example of the benefits of a CBCT versus a 2D image. This PA is for a chief concern of pain on number 15. With the PA, it is difficult to make out whether there's pathology present on number 15 and possibly number 14 with the anatomy that's present. But with the CBCT, you can see there is an obvious infection on number 15 and some infection starting on number 14. So the 3D CBCT just provides that much more clear and comprehensive information. This slide shows a comparison between how a CBCT shows an image compared to a 2D PA. Imagine that a CBCT can show you information as if you're looking at a whole loaf of bread, and the PA is like you're looking at only one slice. If the patient you're seeing in your hygiene chair is interested in getting an implant, a CBCT would help identify if the patient is eligible and the size of implant that is needed. The dentist or specialist will determine if the patient is a candidate by looking at the coronal, axial, and sagittal views of the jaw. The CBCT can also be used to determine and understand proximity to sinuses, major nerves, and other adjacent teeth. There are many different types of implants. I would recommend looking to see what implant system your practice uses and ask your DDS why they like that particular brand to gain a better understanding of the process for treatment planning and determining whether or not a patient is a candidate. Another time it will be helpful to take a CBCT is post-implant placement to assess integration into the bone and to see if there's any compromised areas of healing. After reviewing the diagnostic imaging needed to see if a patient is a candidate and the process for selecting an implant, it is helpful to understand how an implant is placed. Here pictured is the flapless implant placement or hole punch technique. I'm sure you all know how to place an implant or the steps involved, but if you don't, I would suggest asking a DDS or specialist in your practice to review the process, as it is helpful to be able to explain it to patients. I personally have experience with working at a practice where we as hygienists assisted the dentist a few days a week and then had hygiene schedules the other days. Knowing how the process of an implant works, it made me much more confident in speaking to patients about it. Here is a flap implant placement technique called the M-flap. Either way you do it, once the area is prepped, the implant is placed. After the implant has been placed, an abutment or implant screw is placed on top. This will stay in place for 3 to 6 months depending on the healing phase. It's important to know how to care for an abutment while you're waiting for the area to heal before the crown is placed. If the patient ends up in your hygiene chair during that time, during your cleaning, you should carefully remove food and plaque with gauze or scaler if needed. Advise patients to rinse with salt water throughout the day when tissues are irritated and to brush gently around the abutment. Do not scrub. During the healing phase, typically it takes 3 to 6 months to integrate into the bone, but it can depend on the size of the implant and the quality of bone that existed there before the implant was placed. Lifestyle choices or health concerns may also impact dental implant healing times, such as smoking, poor oral hygiene, and uncontrolled diabetes. One important question to ask yourself is, how do I know if it's healed? About 2 weeks after surgery, the implant should be healed with little to no tenderness near the implant, no pain or discomfort, light pink tissues, and no mobility. You know if it's not healed because there could be pain or discomfort, erythema, edema, infection, pus, or mobility. Once it is healed, the abutment will be removed and the crown will be placed. There are 2 ways to put a crown on top of an implant. It can be a cemented crown or a screw retained crown. If you choose to cement the crown, you must be very sure that you remove all of the cement completely and correctly, otherwise periodontal issues can occur. A screw retained crown has a screw tightened in the inside of a crown and the access hole is filled. Sometimes it's not cosmetically ideal and the screw can become loose over time. Loose crowns can result in malocclusion issues and issues with implants as well. So now that we understand the process of placing an implant, let's talk about periodontal classifications of implants and implant health. Peri-implant health means that the implant is healthy. There will be no signs of soft tissue inflammation, no redness, no swelling, no bleeding on probing, and there will not be any additional bone loss following the initial healing. Peri-implant disease, on the other hand, which is considered either peri-implant mucositis or peri-implantitis, can occur. Osseointegrated dental implants have a long-term success rate of over 90%, but they may be threatened by either peri-implant diseases. Perimucositis is very similar clinically to gingivitis. It is reversible, but you will notice that there is inflammation present, redness, bleeding on probing. There won't be any recession or bone loss or mobility, but there will be an increased pocket depth. Peri-implant mucositis is confined to the peri-implant soft tissue, but it is a precursor for peri-implantitis if biofilm is not removed to prevent and manage the peri-implant mucositis. Peri-implantitis, on the other hand, is very similar to periodontitis. It's not reversible and it is progressive. You'll notice patients have inflammation present, bleeding on probing, separation, increasing probing depths, as well as progressive bone loss that is over 2 millimeters from the baseline radiograph when the implant was placed. When there is no baseline radiograph, implantitis is determined by greater than 6 millimeter pocket depths with profuse bleeding. Exposure of underlying implant threads may occur, as well as loosening of the implant, and the bone loss that is present will not be linear. Here is an image that shows the progression of disease from the left image to the right. Here is another change in the bone support around the implant, which makes this patient peri-implantitis. Peri-implantitis risk factors include plaque and/or calculus, diabetes, smoking, excess cement, genetic factors, sometimes systemic conditions, either cardiovascular disease or rheumatoid arthritis, malocclusion, implant position, quality of bone grafting, poor treatment techniques, and/or infrequent or irregular maintenance schedules. If you have a patient with peri-implantitis in your chair, a possible chief concern might be bad breath, pus or bleeding, a loose implant, swollen gums, pain, fever, or difficulty chewing. Implants can fail at various stages in treatment. Early implant failure is often due to the lack of initial osseointegration. It can be associated with impaired healing responses, infection, premature loading, and/or surgical trauma, whereas late implant failure occurs after the initial phase of osseointegration, remodeling, and loading. It's often associated with occlusal overload, prosthetic failure, and peri-implant disease. Our next topic is going to be implant care and maintenance and what's needed. These are some examples of assessments that need to be completed at recare visits for patients with implants. Identifying these assessments will determine if the patient is implant health, implant perimucositis, or peri-implantitis. Soft tissue is important to assess, and you want to document tissue consistency, contour, and color. It's also recommended to document plaque index at every maintenance visit. Next, probing depths are needed to determine health of the implant. It's also important to note that less probing force is needed, and it's recommended to wait at least 3 months after placement before probing the implant. Documenting bleeding on probing is important because bleeding on probing indicates disease, and absence of bleeding is an accurate indication of implant stability and health. It's important to know which probe you have at your practice and the amount of force that has to be applied when probing an implant. If you have a bigger plastic tip, you have to apply more pressure, whereas if you're heavy-handed, you could potentially poke right through the epithelial attachment, and you have to be consistent. Some additional implant assessments that need to be done during hygiene visit are to look for separation, as this can be associated with implantitis and can be an indicator that intervention is needed. Also, looking at the soft tissue margins and evaluating to see whether or not there's any recession. When there is recession around an implant, it can expose rough implant structures, which accumulate plaque and could lead to inflammation and possibly the development of mucositis or implantitis. Mobility and occlusion are two critical assessments that also need to be made during a recall visit to assess the health of an implant, because there is a direct correlation between occlusal overload and peri-implant bone loss. The elimination of 85% of plaque or biofilm on a daily basis is critical to the overall health of the implant. Excellent adult oral hygiene routine plus maintenance can increase implant success to 90%. Here are some non-surgical options for caring for implants. These include patient education and management of risk factors for peri-implant diseases, incorporating plaque control measures, peri-implant scaling, either with manual instruments that are made out of titanium or ultrasonic scaling instruments with a titanium tip, antimicrobials, subgingival ear polisher, laser disinfection, local delivery of antibiotics, understanding malocclusion and how teeth function together, and also making sure that patients adhere to a 3-month perio maintenance. If your patient has healthy implant tissues, here is an example of what can be done during a recare visit. We know, as previously stated, that removal of plaque and bacteria with a titanium-tipped ultrasonic or scaler is optimal in maintaining implant health. You can also use a rubber cup with neutral pH polish and also adhere that patient to a 3-month maintenance visit. Some non-surgical options for treatment of mucositis for your patients in your hygiene chair could also include removal of plaque and bacteria. As we know, mucositis is reversible, so removing that layer of biofilm is critical to maintain patient implant health. These patients are also candidates for rubber cup with neutral pH polish, as well as irrigating with some type of rinse like Closis or whatever you use within your practice. We could also look at using subgingival chemotherapeutics and or placement of Arrestin if the pocket allows for it. These patients would also be candidates for guided biofilm therapy with an airflow polisher or laser use. Either way, patients with implants with mucositis should maintain a regular 3-month maintenance interval. If you have a patient that presents in your hygiene chair that has implantitis, it is recommended to refer to a specialist because surgical intervention may be needed. Our last topic is going to be discussing what is needed for maintenance visits and caring for implants. First on the list are titanium instruments. They are most recommended outside of air polishing for implants, are most compatible with them. They are recommended over plastic instruments because the plastic can be left behind and damage the implant surface. Just have to be careful with titanium instruments not to damage or scratch the surface of the implant. Next, GC Triplaque ID Gel is a disclosing agent and is a really great patient education tool and can help with the assessment of plaque present on the implant. Once applied in the mouth clinically, you can get a mirror or take an intraoral photo to show the patient areas that they're missing in relation to biofilm removal on the surface of the implant. A more recent phenomenon and heavily researched area is airflow polisher or guided biofilm therapy. This uses regulated warm water, compressed air, and very fine powder materials to effectively and gently remove biofilm from the surface of teeth and implants. Recently, this is something that a lot of clinicians are using to maintain tissue health. Another option for your practice, if you have one, are to use lasers. They do not damage the implant surface, and they can decrease clinical signs of inflammation at 3 months and bleeding on probing at 6 months after treatment. On this slide are some different options of subgingival chemotherapeutics that can be used during implant care. The first one, Hibenex, reduces bleeding by eliminating bacteria and treats mucositis and implantitis. It can tell the difference between infected and healthy tissues and removes the harmful pathogens. Next, Aresin is site-specific, and it is a local antibiotic that remains in the pocket for 14 days. And lastly, Cervitec is a varnish for germ control and is recommended to apply at every 3-month visit. As you can see, all of these adjunct therapies can be billed using D4381. The topic of antimicrobials has been showing in recent research that chlorhexidine can inhibit the potential for re-osteointegration. So Clocis is often being used by more specialists for its antimicrobial benefits. And lastly, the product that is important to know about that a lot of specialists use is Stella Life. It improves recovery, decreases need for opioids, reduces discomfort, and is fast acting. It's recommended to do the 333 program where you use all 3 products in the recovery kit for 3 days prior to your procedure and use them 3 times a day. Okay, this concludes information for the presentation, and I wanted to review what comprehensive implant training would look like in your practice. We review what makes a patient a candidate, diagnostics and choosing an implant. We review implant placement, periodontal classifications, as well as implant care and maintenance in dental hygiene. We review what's needed. We go over staging and grading and soap notes, home care recommendations, imaging protocol, coding, and fees. We appreciate you attending the Lucrative Lunch Hour. As a benefit to attending, we offer a $1,000 off placement through dental recruiters within the next 90 days through April 25th, 2025. We also offer $700 off a DCC practice analysis that is scheduled within 15 days after our webinar. We also offer in-office training on current Lucrative Lunch Hour topics, 3 hours of CE for the team, as well as guest speaker at study clubs, district meetings. If you're interested, please email hello@dentalconsultingco.com. Please feel free to reach out with any questions that you might have. We look forward to hearing from you and working with your team in the future.